Welcome everyone, hello respected seniors and dear colleagues. My name is Dr. Mohammad Farhan, working as a postgraduate resident neurosurgery, and today the topic of our discussion will be Atlantoaxial subluxation and fractures. Especially, we are going to discuss the management of Atlantoaxial subluxation and different types of fractures. We are going to discuss the management of Atlantoaxial subluxation and fractures. The objectives of our today that we are going to first discuss the anatomy of C1 and C2, then the key stabilizers which influence the management options and detect the different investigations which are available for the proper diagnosis, and then proceed to the further management of each C1 and C2 and different types of fractures according to their classification. And we are also going to discuss the different techniques available for their fixation, fusion and stabilization of these injuries. So first of all, uh, we should know the anatomy of the atlantoaxial complex. As we know that the C1 vertebra is a ring-like vertebra with an anterior arch, posterior arch, a small spinous process, and lateral masses and transverse processes which contain the foramen transversarium. And the main stabilizers of C1 and C2 are the ligaments. The main ligament in which is the uh, transverse ligament of atlantoaxial complex, and other ligaments which can stabilize the atlantoaxial complex are the alar ligaments or the anti-tectorial ligament, and apical ligaments are the some other ligaments. So this is also another view of the main stabilizer of the atlantoaxial complex, which is the transverse atlantoaxial ligament. It has bands, superior band and inferior bands, and the two lateral bands. The other, we can also see the apical ligaments and the alar ligament. So the main stabilizer, as we know that it is the transverse atlantal ligament, and the main treatment will, the main management of our focus will also be on the transverse atlantal ligament. We should know that if there is any tear or any disruption of the transverse atlantal ligament, then the C1 C2 complex or the atlantoaxial complex will not be stable. If the ligament is intact, then we can say that the C1 C2 is stable, and there may be some range of motion, and there may not be any chances of any deficit in the future. Then the secondary stabilizers are the alar ligaments, which limit the rotation and lateral flexion, but these are not as very important as the transverse atlantar ligament. The main influence the main ligament which influences our management will be the transverse atlantal ligament. So we should completely know about the anatomy and different tears and disruptions of the transverse atlantal ligament. Then the tertiary joint capsule may stabilize the uh, C1 C2, but up to a limit. So as we know that the main stabilizer is the transverse atlantal ligament. So spine is stable or not, or the transverse ligament is intact or not, how we can know that? For this we can uh, have three investigation. The first one is the open mouth x-ray. As we can see that in the open mouth x-ray, we can see the odontoid process C2 and the lateral masses of the C2, and above that are the lateral masses of the C1. And as we can see that the lateral masses of C1 and C2 are well aligned in the normal anatomical position. This is the normal alignment of C1 and C2, and when this alignment is present, we can say that the transverse atlantal ligament is intact. When this alignment is not present, for example, when there is overhanging of the C1 C2 lateral masses over the when there is overhanging of the C1 lateral masses over the C2, we can say that the transverse atlantal ligament is not intact, or there is maybe some disruption or tear in the transverse atlantal ligament, and the spine may not be stable. Usually the diameter, both the collective distance of overhanging of the C1 should be greater than 7 mm, or in some books it is written as 6 mm. So if the total overhanging distance is more than 7 mm, we can say that transverse atlantal ligament injury is present. Then the second point to or the second investigation we can do is the CT cervical spine lateral view or the X-rays cervical spine lateral view, which can tell us about the atlantodental interval. So atlantodental interval uh, is another modality through which we can confirm the or we can have an idea about the stability of the transverse atlantal ligament. As we can see in the picture that the distance between the anterior arch and the dense process, the distance between the anterior and dense process is called the atlantodental ligament. Usually in adults the distance is usually less than 3 mm, and when the distance is less than 3 mm we can say that the transverse atlantal ligament is intact. And if it is greater than 3 to 5 mm, then they may be highly suspicious of transverse atlantal ligament injury. And if the distance is greater than 5 mm, the other accessory ligaments such as the LR ligament may also be injured in this process. So we can have discussed that transverse atlantal ligament can we can have idea about the injury of the transverse atlantal ligament through the open mouth X-rays, which shows the overhanging of the lateral process of the C1, and we can also have an idea through the atlantodental interval. Then the confirmatory test for transverse atlantal ligament injury would be the MRI. As we can see that in this image, in the image A, there is a band like behind the dense process, that is the transverse atlantal ligament seen. And in the image B, we can also see the LL ligaments. And in this picture, we can see that there is in the MRI, we can see the transverse atlantal ligament injury. We can see that there is a missing of the band posterior to the dense process. So, a transverse atlantal ligament, when there is disruption, there may be there may be destabilization of the C1, C2, and we may need to fix that. There may Dickman classified the transatlantal ligament injury into the type 1 and type 2. Type 1 injury is that there is disruption of the ligament substance, or there may be disruption in the or tear in the ligament. But in type 2, the transatlantal ligament avulses from the bony attachment. There may also be associated bony attachment, or there may be associated fracture in the type 2. Usually the management for type 1 is usually in type 1 the type 1 is very unstable. When there is a tear in the ligament, in the type 1 Dickman classification, there is instability, so we may need to fix the C1 C2 or fuse the C1 C2. But in type 2, the external mobilization through rigid collar or the hollow vest can be done, and the bony avulsion heals spontaneously, and the ligament then stabilizes. Usually for the type 1 we should go for the surgery and fusion, and type 2 we can externally immobilize and wait for 3 to 6 weeks for the proper healing. Then there is another classification of the C1 fracture. As we can see that we have discussed different types of classification, such as in this Gaviller classification, and similarly to the Jefferson classification, which has fracture of the anterior arch, fracture of the posterior arch, and fracture of both arches, anterior and posterior, and fracture of the lateral meshes, and the transverse process. So are all these types of the classification, and all according to the classification we can have an idea that if the spine is stable or not. Usually in the fractures of the anterior and posterior arches, we can see that the spine is usually stable. In the posterior fracture, usually the fractured part moves posteriorly, and the cervical spinal canal is usually widened or does not affect the stability. So the for the anterior and posterior fractures in the class 1 and 2, there may not be need to be fixation or go for the surgery, and usually conservative management or immobilization by external halos or rigid collar can be done, and usually the fracture heals itself. Then if there is a fracture of both anterior and posterior arch, there may be associated transverse atlantal ligament injury. So, in when there is a transverse atlantar ligament injury, we should go for the surgery, as transverse atlantar ligament injury causes instability. So, usually in the that 3A and 3B, that are the Jefferson type fractures usually. So, we should go for the surgery. And usually in the fractures of the lateral processes, the spine is usually stable and the ligament is not disrupted. So, we can also keep conservative or external immobilization in the lateral process fractures, and in the transverse process fracture usually surgery is usually not needed, but in the transverse process we should also go for the CT angiography, because there may be injury of the vertebral artery, or leading to the vertebral artery thrombosis. So we can see that the anterior arch is usually non-surgical, posterior arch is usually also non-surgical. Both arches, if the tall is intact, confirmed, which can we can confirm with the MRI. Tall we can confirm with MRI, with open mouth X-rays, and with the atlantodental interval. So usually hard collar or close follow-up in if tall is intact. If tall is disrupted, surgical stabilization is needed. In usually lateral masses fracture, that is also non-surgical, and in the transverse fracture, the treatment is also usually non-surgical. Then in the odontide fractures, as we can see that Anderson and D. Alonso classification, there is type 1, which is usually the tip of the fracture, or type 2, which is usually the dense body process fracture at the base, and usually type 3, in this is the usually body is fractured along with the dense process. So in all these types, the treatment will be different. In the type 1, usually these are stable. So we should the treatments should be non-surgical. But in type 1, there may be associated occipital destabilization. So we should also look for that. But for atlantoaxial, we should go for conservative in type 1 fractures. And in type 2, usually these are very unstable, and we should go for the surgery. We are going to discuss the different surgical techniques in the upcoming slides. And in the type 3 is usually also stable, and usually the treatment option would be non-surgical. As we can see that avulsion at the dense of the tip, there may be external immobilization with rigid collar or hollow vest, and then wait for 3 to 6 weeks for the proper alignment and proper healing of the bones or the fracture parts. And usually the treatment option for would be if there is a type 2 fractures, and type 3 is usually also conservative with the external immobilization. Then the fractures of the body and different complex and body and its complex fractures. Usually, most body fractures are usually non-surgical. If there is isolated fracture of the body, as we can see in one slide, in one of the CT scan, there is a fracture of the body. Usually, these are stable fractures, and usually it all is not disrupted in these injuries. But we can confirm with the MRI. So the treatment would be non-surgical, stable, minimally displaced collar for 6 weeks, and hollow or hollow vest or rigid collars can be applied for 8 to 12 weeks. If there is also body, pedicle, or lateral massive fracture, usually these are stable. Uh, but if there is a retropulsion, or there is narrowing of the spinal canal, then we should go for the fusion or surgical options. Then in the anterior subluxation, or the atlantoaxial subluxation, as we can classify the different types of subluxation depending on the through the Fielding and Hawkins classification. As we can see in the type 1, then in the anterior subluxation, or the atlantoaxial subluxation, as we can classify the different types of subluxation depending on the through the Fielding and Hawkins classification. As we can see in the type 1, there is bilateral facet injury, but the C1 moves anteriorly, but all is intact in this. So there would be the treatment would be non-surgical if the tall is intact, and usually these can also be stabilized by external immobilization. Then in the type 2, 3 or 4, there may be surgical options as the tall is injured. So the spine is very unstable in this, or the atlantoaxial complex is very unstable in these injuries. So we should go for the surgical options. As we can see that in type 1 collar and analgesia conservative, 2 in 2 and 3 we can apply the traction, and then according to the MRI if tall is injured. But in 2 and 3 type 4 requires surgical stabilization. But in 2 and 3 the different books have recommended different options, and it depends on the surgeon's preference whether to fix these or fuse C1 or C2, or manage with the external immobilization. Usually if external immobilization with external immobilization, and after 10 to 12 weeks, if stabilization is not achieved, then we should go for the surgery. We can check the stabilization also through the dynamic x-rays. Then there is a hangman's fracture. As we know that the hangman fracture is the fracture of the pars or interarticularis or the pedicles, and these may be associated with the spondylolisthesis of the C2 over C3, may or may not be associated with listhesis of the C2 over C3. And Levine and Edward classification is done dividing the hangman's fractures into into three types, and depending on the age type we can decide the surgical options. As we can see that in the type 1 usually it is stable, and we should go for the external immobilization. In type 2, reduction then halo fixation, or if the fixation is not achieved with the external immobilization, then we can go for the C2 C3 fusion. And in the type 3, surgery is usually recommended because there is facet dislocation, and the spine is very high, unstable, and also there is a listhesis narrowing the spinal canal. So we should go for the surgery in the type 3. Then there are different options for the stabilization, or the different surgical options. There are some techniques such as the wire techniques and screw fixation. Different wire techniques are available, such as the main wire techniques are the galley dorsal wiring, Brooks and Jenkins, and Sontag's modified galley technique. So we are going to discuss one by one each of these techniques. Usually the wiring technique does not apply nowadays because it does not achieve as much stabilization as the screws. But these can be used for the reinforcement, in the reinforcement of stabilization. In the galley dorsal technique, we can see that the wires are passed anteriorly to the lamina of the C1, and then the wire is passed inferior to the spinous process of the C2, and then an H-shaped bone graft is placed over the spinous process of C2, and then these grafted are tied with the wire. There is single sublaminar pass under C1 only. The wire is passed through C1 only, and and an H-shaped bone graft is placed. And then fixed, and wires are tied. Uh, so this is the galley dorsal technique, and usually it has a high failure rate of 25 to 80%, and but the it can be used for reinforcement in some cases because it is faster, less bleeding, less fluoroscopy, or lower cost. It can be used in pediatric patients. Usually the wire techniques are used in pediatric patients. We can also see the post-op X-ray of the this galley technique. There are wires and the bone graft. Then Brooks and Jenkins. Similarly in the Brooks and Jenkins, the wires are passed through sublaminar or anterior to the lamina of the C1, and then the bone graft are usually in the galley technique one bone graft is used, but in the Brooks and Jenkins two bone graft are used and are placed between the C1 and C2. And then the Sontag's modified galley fusion. In this, similarly, it is similar to the galley fusion technique, but a single bone graft is used between the cortical interfaces or the inferior rim of the C1 arch and the rostral margin of the C2 lamina, and these are fixed. Usually, these wiring techniques are not used when there is a fracture of the posterior arch, or the posterior arch is fractured or not present. Then we cannot use these techniques. Then the screws techniques. First one is the magral transarticular screw fixation. So in this technique, the transarticular screws are placed. As we can see, the screws are placed from the C1, from the C2, and then through the articular faces of the joint, and then placed into the lateral masses of the C1 vertebra. And through this, fusion is achieved, and usually these articular surfaces are fixed. We should do the reduction before screw placement, and uh, we cannot reduce through the screws, but we can fix C1 C2 after reduction through these screws. uh, it is a highly complex technique because it has a high chance of a vertebral artery injury. As we can see that the vertebral artery passes through the foramen transverse cerium, which is just lateral to the uh, lateral masses, and then it arches superiorly over the groove through the C1 vertebra. So, fine cut CT should be done to assess the vertebral artery position, and then go for the surgery. We can see the post-op X-rays after this magral transarticular screw fixation, and usually these screws are placed in the anterior arch. The end of these screws are placed in the anterior arches of C1. Then the most commonly used techniques nowadays are the Goel-Harms technique, that is the C1 C2 fixation through the screws and rods. This is also called the C1 C2 cantilever technique. We can see that the C1 screws are placed in the lateral masses, and the C2 screws can be placed over the pedicles of the C2. Usually the 3.5 mm screws are used in both the magral technique and the C1 C2 technique, and these after placing the screws fixed with two rods. So C1 C2 fusion is achieved in this. Because it has a high chance of bleeding from the vertebral paravertebral venous plexus, and because while dissection, after dissecting the spinous process and lamina, when we go to the uh, articular surfaces of the C1 and C2 articular joint, there is a C2 nerve root which is retracted laterally, and then lateral masses of the C1 are exposed, and then lateral masses of C2 may also be exposed. But we should also keep in mind that further lateral dissection can injure the vertebral artery. Then there is C2 laminar screw placement. In some cases, the screws in the lamina of the C2 can be placed, uh, because in some cases, when the pedicles are not very thick or very thin in some cases where there are very thin pedicles, the laminar screws can be placed. We can also prevent the vertebral artery injury and the bleeding from the venous plexuses or by placing these screws. But in this technique, there is a high chance of going into the spinal canal. So we should look for these pros and cons. But this is also another technique for the C1 C2 fixation. Translaminar screws can be placed in the C2, and the C1 screws are usually placed in the lateral masses. We can see the post-op X-rays after placement of these screws.
रॉड लगाना बड़ा मुश्किल हो जाएगा।
नहीं सर, वो फ्रेम आता है इसका दूसरा ना, मैंने तस्वीर देखी थी, फ्रेम ऐसे आ जाता है। और यूजुअली ये जो होता है ना, ये C3 भी जब साथ फिक्स करना हो ना, तो ये यूज़ करते हैं सम टाइम। तो फिर वो रॉड एक अलग इसको साइड पे लग जाता है। Then odontide screw placement. In the fractures, in the type 2 odontide fractures, we can place the odontide screws anteriorly. Usually, when there is a fracture, type 2 fractures, yeah, and fusion is achieved by the placement of a single screw which is passed through the C2 vertebral body, or just in the intervertebral disc between the C2 and C3, and is placed superiorly and posteriorly, and usually it is passed through the fractured body. As we can see, the screw is passed through the fractured body. uh, we usually do the give the incision at the level of the C5 C6, and then the section is done. The neck structures are separated, and we reach at the vertebra. Then C2 is identified, and C dissection is done between the C2 and C3. We can remove the C3 or the intervertebral disc of the C2 C3. Then the direction is that it is from the inferior of the C2, and it is inserted in the uh, fractured body. Usually, the if there is a fracture line that is passing from the anterior inferior to the posterior superior plane, usually this is contraindicated, but can be done in. But some surgeons do apart from the fracture line if there is instability in the or the in the type 2 fracture. Usually screw is placed. uh, in transverse ligament disruption, some books have suggested that C2 odontide screw placement should not be done in transverse ligamental disruption, but I could not find the reason why they said that. And in irreducible fractures, if the C2 fractured body is high above, that screw is not reached there, or the C2 usually while placing these screws, the fractured part of the C2 odontide is reduced orally. The patient lies supine, and we can reduce the C2 fracture through orally by placing a hand over the posterior pharyngeal wall, and it compresses the odontide, and then screw is placed. In some cases, such as the barrel chest, short neck, or kyphosis, the direction of a screw cannot be formed properly. So, in these cases, it may be very difficult to place the odontide screw. And severe osteopenia, if there is not a proper purchase of the screws, then they may not be the feasible. Usually, in the posterior approach, usually 3.5 screws are used, and in the odontide, 4 to 5 screws can be used. So these are the techniques. We have discussed the wire techniques and the screw techniques. As we can see, this is the comparison of these techniques. In the wire technique, usually the post-op external immobilization with hollow vest or rigid collar is usually required, but in usually 3.5 screws are used, and in the odontide 4 to 5 screws can be used. So these are the techniques. We have discussed the wire techniques and the screw techniques. As we can see, this is the comparison of these techniques. In the wire technique, usually the post-op external immobilization with hollow vest or rigid collar is usually required, but in screw technique, no post-op external immobilization is required because we have achieved maximum stabilization with screws and rods. Usually the rotational control is better or improved in some wiring techniques, but rotational control is very rigid in screws techniques. So this is the summary of our today's class. So thank you very much. Anyone have any questions, or anyone have any comments?
इसमें ये है कि जो वायर टेक्निक्स है ना वो अपसलेट हो गई थी है। मैंने
Yes, sir.
तो वहाँ जनरल हॉस्पिटल में 5 साल में कभी भी नहीं देखा, अब कोई भी नहीं करता। लेकिन जो ये ट्रांसओरल है ना, वो डेंड्राइट का अगर फ्रैक्चर है तो उसमें जो स्क्रू लगाते हैं वो हमने कुछ किए हुए हैं।
नहीं,
लेकिन वो भी बड़ा डिफिकल्ट प्रोसीजर है।
ट्रांसओरल सर वो भी आजकल कम हो रहा है,
बहुत
लेकिन
कम
वो
होता
ज़्यादा
है।
ये इंटीरियर वाले स्क्रू जो ओडोंटाइड स्क्रूज हैं वही लगते होते हैं।
ट्रांसओरल मैंने एक आध देखा है लेकिन बहुत ही मुश्किल उसकी पोजीशन, फिर वो माउथ ओपन करना,
हाँ जी।
उसके रिट्रैक्टर्स और फिर ब्लीडिंग और फिर
हम्म,
मल्टीपल इश्यूज हैं, बड़ा मुश्किल है।
वो मुश्किल था इसीलिए
आजकल
मैंने पढ़ा भी नहीं है।
आजकल रूटीन में जो काम हो रहा है ना, वो जो हमने एक केस किया था C1 C2 फिक्सेशन, कि आपने C1 का लेटरल मैस और C2 का पेडिकल, उसमें स्क्रू लगाने हैं, सबसे
हम्म।
इजी और रूटीन में वही हो रहा है। तो वाइबे के लिए यही है कि आपको नाम वगैरह सारे आने चाहिए, लेकिन ज़्यादा जो डिटेल आनी चाहिए ना, जो प्रोसीजर आपको अच्छा आता है, जो आपने देखा हुआ है, वो आपको उस पर ग्रिप अच्छी होनी चाहिए। बाकी अच्छी प्रेजेंटेशन है, डिटेल्ड है, क्लासिफिकेशन भी सारी अच्छी हैं, डिटेल में है। अब इसमें एक थोड़ा सा मेरा कंसर्न है, जैसे हम ACDF कर रहे हैं, सब एक्सियल में ACDF करते हैं, C1 C2 में कोई ऐसा प्रोसीजर है जिसमें फ्यूजन फ्यूजन की जाए?
सर C1 C2 में ओडोंटाइड स्क्रूज ही लगा सकते हैं, क्योंकि बट वो डिस्क तो है नहीं। लेकिन C2 C3 में वो जो होता है स्लाइस्थीसिस होती है साथ हैंगमैन फ्रैक्चर में, उसमें किया जा सकता है।
C1 C2 में इंटीरियर सिर्फ एक स्क्रू है जो आप
स्क्रू
लगा
है,
सकते हैं,
सिंगल 4 mm का एक स्क्रू बस।
ठीक है, और वो भी ओडोंटाइड का फ्रैक्चर है तो उसके
ओडोंटाइड
लिए।
का फ्रैक्चर है।
वैसे इंटीरियर कोई भी प्रोसीजर C1 C2 के लिए नहीं है। वैसे भी अगर आप रूटीन में देखें तो जो डिस्क डिजीज है वो तो ज़्यादा C5 6 है या 6 7 है, और अगर पोस्ट ट्रोमैटिक है तो वो भी ज़्यादा सब एक्सियल है। C1 C2 के ऊपर डिस्क डिजीज नहीं होती, बहुत कम है। एक इसमें ओसी भी करते हैं ना, जो ऑक्सीपिटल सर्वाइकल है, लेकिन वो इंडिकेशन डिफरेंट है।
वो ये डिफरेंट है
ये
अगर
आपने बेसिकली आपका टॉपिक जो है ये सिर्फ C1 C2 था,
C1 C2 का।
एटलांटोएक्सियल सबलक्सेशन थी, वो अगर ऊपर इंजरी हो तो उसमें फिर OC करते हैं। उसमें भी यही है कि ऑक्सीपिटल स्क्रू लगाते हैं, और C1 का लेटरल मैस होता है, C2 का टीपी होता है, लेकिन उसमें जो प्लेट लगाते हैं ना ऑक्सीपिटल,
हम्म।
वो प्लेट ऐसे होती है जैसे ये दरवाज़ा होता है ना, वो वाला आपका स्लाइडिंग वाला,
हम्म।
वो प्लेट यहाँ पे स्लाइडिंग वाली लगती है। ठीक है,
वो
वो
ऐसे ऊपर
स्लाइडिंग
नीचे
में
हो
ये
जाता है।
बेनिफिट है कि आप नेक को ऊपर नीचे कर लेते हैं,
हम्म।
तो वो जो आपका इम्प्लांट है ना, वो उसके अंदर ऊपर नीचे मूव
ऊपर
करता है,
नीचे मूव।
जिस तरह दरवाज़ा ऊपर नीचे मूव करता है। वो रिसेंट अभी मैंने देखी है, पिंडी में की है उन्होंने, ओसी ऑक्सीपिटल सर्वाइकल, उसमें उन्होंने प्लेट वो यूज़ की है जिसके अंदर वो स्लाइड है। तो स्लाइड का ये बेनिफिट है कि आप नेक फ्लेक्शन और एक्सटेंशन इजीली कर सकते हैं। ये जो C1 C2 की इंजरीज है ना, इसमें ये याद करना ज़्यादा ज़रूरी नहीं है कि किस में इमोबिलाइजेशन है, किस में इमोबिलाइजेशन है, वो ज़्यादा है। आपने सिर्फ ये याद रखना है कि सर्जरी किस में है,
हम्म।
सर्जरी बहुत कम में है। ये जो आपकी मल्टीपल क्लासिफिकेशन है ना, जैसे 4 या 5 है, उसमें से एक आध ऐसी है
एक आधी
जिसमें
ऐसी है
सर्जरी है,
जिसमें सर्जरी।
बाकी सब में इमोबिलाइजेशन है। रूटीन में आपने फिलाडेल्फिया कलर यूज़ करना और इमोबिलाइज करना है बस।
कि ये जो स्क्रू है ना ये लेटरल रोटेशन को बिल्कुल फिक्स कर देता है। ठीक है, क्योंकि वो C1 C2 पे ही लेटरल रोटेशन होती है ज़्यादा। तो ये है कि ग्रोथ भी होनी होती है बच्चों में। तो यूजुअली इस टेक्निक के साथ ही फिक्स किया जाता है अगर कोई इंडिकेशन बन रही है फिक्सेशन की।
और दूसरा ये है कि दूसरा कॉलम कॉलम थ्योरी आप देखें ना, कि इंटीरियर मिडल पोस्टीरियर कॉलम है, तो जो आपकी वायरिंग टेक्निक है ना, वो सिर्फ आपका पोस्टीरियर कॉलम को इन्वॉल्व कर रही है, पीछे पीछे आप लगाते हैं। जो आपका स्क्रूज की टेक्निक है वो आपका मिडल और इंटीरियर तीनों कॉलम को इन्वॉल्व कर लेती है।
C1 का स्क्रू है वो इंटीरियर आर्च तक जा रहा होता है।
उसमें फिर आपकी जो रोटेशनल मूवमेंट्स है ना वो कम हो जाती हैं, लेकिन अगर आप सिर्फ पोस्टीरियर कॉलम यूज़ करें, आप सिर्फ लेमिना या स्पाइनस प्रोसेस है वहाँ पे ग्राफ्ट ला के उसको टाई करें, तो आपकी रोटेशनल मूवमेंट्स सिक्योर रहती हैं। अब जैसे ये हमारे पास एक पेशेंट ICU में जिसकी C3 से लेके C7 तक कंट्यूजन है, उसमें हम कुछ कर सकते हैं?
इसमें सर C3 से C7 तक उसमें करने की ज़रूरत तो नहीं है अगर उसका वो क्या कहते हैं CT पे हमने देखा है कोई बोनी फ्रैक्चर नहीं है, कोई इंजरी नहीं है। लेकिन MRI पे हम टाल देख सकते हैं कि वो स्टेबलाइज है कि नहीं है।
C1 C2 तो उसमें इन्वॉल्व ही नहीं है ना, नीचे
हाँ।
है।
तो
तो मेरा ख्याल है ये किया जा सकता है कि अगर हम उसको बेनिफिट देना चाहें ना, तो लेमी करके और लेटरल मैस कर दें।
उससे
इसका C3
डिकम्प्रेशन हो
C4
जाए।
C5 C6 इसकी लेमी करें, पीछे सारा ओपन कर दें और उसका लेटरल मैस करके फिक्स कर दें, तो शायद उसकी जो इंजरी है वो जल्दी बेहतर हो जाए, डिकम्प्रेशन हो जाए। और ये जो C1 C2 है ना, ये सर्जरी बहुत मुश्किल कंसिडर की जाती है, हर सर्जन नहीं करता, बहुत कम सर्जन है ये करते हैं, क्योंकि इसमें रिस्क बहुत ज़्यादा है, इसमें VA के इंजर होने का बहुत ज़्यादा रिस्क है, क्योंकि अब मेजॉरिटी लोग ये नहीं करते। वैसे तो फॉरेन कंट्रीज़ में तो ये होता है ना कि काम को वो डिवाइड कर देते हैं कि C1 C2 अगर किसी सर्जन को अलॉट कर दिए ना, तो वो C1 C2 ही करता रहता है। वो 100 केसेस उन्होंने C1 C2 के किए होते हैं, वो बड़े यूज टू हो जाते हैं, बड़ा अच्छा कर लेते हैं।